This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Well, welcome to our podcast on the geographic and racial disparity in the treatment of cardiovascular disease. And with me today, I have two guest speakers, really fabulous. One is a cardiac surgeon, Dr. Antoine Keller, cardiovascular and thoracic surgeon in Baton Rouge in Louisiana. And to say that Dr. Keller is well-traveled is probably an understatement, since he's a native of Louisiana and then followed his father on a PhD thesis in Kenya and then Ethiopia. Then headed for the west coast of California and studied at UCLA, to be followed by Duke University for his medicine, and finally completed his training at Tulane University. Dr. Keller, welcome to our podcast. And Dr. Stephen Clarkson, undergraduate in medical school at University of South Carolina, now at UAB, and basically starting as assistant professor of cardiology, and particularly interested in the field of research of disparity. Steve, again, thank you very much for agreeing to do this. And Dr. Keller, welcome to our podcast.
Thank you, Dr. Bouchard. Pleased to be here.
So in general, health and healthcare disparities refer to differences in health and healthcare between groups that stem from broader inequities. The CDC identifies health disparities as preventable differences in the burden of disease and also opportunities to achieve optimal health that are experienced by socially disadvantaged population. So health equity generally refers to individuals achieving their highest level of health through elimination of these disparities in health and healthcare. So in this podcast, we'll try to address some of these barriers to health equity. And we'll start by discussing maybe in general the patient and the physician. And then we'll focus our attention on the healthcare system, particularly as it relates to congestive heart failure, and finally to aortic stenosis. So let's start with the patient. From their perspective, healthcare may not be the first or even the second priority for a patient after hospitalization. Rather, the priorities may be food, housing, employment, or even a sick member of the family. Only after these fundamentals are taken care of can a patient focus on their health, their heart failure regimen, or their salt-restrictive diet. Of these patients, often they're labeled non-compliant or frequent flyers, and we assume that they do not take care of themselves very well or take their health very seriously. But it may be that they may have more important concerns. Actually, as a matter of fact, it happened to us last week where we had to wait a year before replacing the aortic valve on one of our patients who had to make sure that his sick wife, was well taken care of. Recently, Ascension implemented a social determinants of health screening that may include transportation, employment, food, and safe housing, with resources for physicians that include the 211 Helpline Center. This is available in portions of all 50 states and Puerto Rico, and is a service provided by the United Way. I just had the chance actually to use that phone number, last week, and I thought it was very, very efficient. You call 211, with the patient there in the room. Someone answers, which is really kind of wonderful. They ask for the zip code of the patient and what their needs are. I had 3 patients, some were, maybe needing some social health with their housing, trouble with neighbors. One of them was about the CPAP. Antoine, what has been your experience with these kind of resources? Have you had the chance to utilize some of them in Louisiana?
Well, I think they're fantastic for a number of reasons. And for the audience, I think that it is really important for us to define some terms, for instance, the differences between disparities, health disparities, and health inequity. The way I like to think about it, disparities are what we have discovered based on outcomes or incidents of disease that we have in the community. And inequities are a function of processes that allow patients to be presented to physicians who can take care of these disease processes or outcomes that we generally define as being disparities. And I think it's an important distinction to make because many of the institutions, such as the ones that you have just described, the United Way and so forth, really do have an impact on these inequities in the system, social determinants, political determinants, institutional determinants, all of these things that impact whether a patient presents to a clinician and receives a diagnosis or some treatment for this healthcare disparity. So these kinds of institutions that are aimed at reducing disparities will most likely impact those disparities by focusing on things that prevent patients from receiving the care that they need to be able to overcome these barriers to adequate treatment. Dr. Clarkson and Dr. Johnson are very familiar, and as I'm sure you are, with the fact that some of these disparities are generations long in the making just because of the fact that we have so many determinants of healthcare that impact patients way before they even come to the to be known by their clinician as having these problems. So the United Way and the Salvation Army and the American College of Cardiology and all of these other institutions that really do have an understanding of the fact that there are determinants of healthcare that have nothing to do with the pathophysiology of the disease directly, but certainly do indirectly impact them quite significantly.
How about you, Steve, at UAB?
You know, I think I agree with everything that Dr. Keller was saying. You know, at UAB, within the community, UAB takes care of a larger portion of indigent patients. And I think with this, you get to see this intersection of accessing care being kind of a problem. And then once you get into care, maintaining access to that care is another issue. And I think those kind of go hand in hand at understanding what's the basis behind these so-called disparities and identifying these inequities to try and fix that disparity, as Dr. Keller said, right? The disparity is the in part of the equation, and the inequities that we have are kind of in the middle of the equation that produce these health disparities. I think what's important is to notice kind of some of the anecdotal stuff we've talked about here. I think the one thing that kind of runs through everything, and the primary thing, I think, when it comes to some of my interests, like in rural healthcare, is what's paramount to what you said, Dr. Bouchard, and Dr. Keller said, is a central theme of this is still the access to quality health services, right? You still have to have the patient in your room to call 211. The patient needs to make it to your hospital for you to identify the problems. And in fact, there was a nice paper, Dr. Bolin, I think it was about 4 or 5 years ago in the Journal of Rural Health, that said they interviewed kind of stakeholders in healthcare, particularly patients, and asked what was the biggest barrier to optimal health. And by far and away, the number one thing that was said was access to quality health services. So I think that, you know, the fact that we've started to recognize these health disparities and these health inequities gives us more credence to increase this access to be able to address these problems when the patients come into the office.
As physicians, we're trained to treat patients equally, and all of us believe that we do a good job. We do that very well. However, in clinical practice, sometimes implicit or unintended bias can interfere with patient care. Implicit bias is basically the way the brain works and process all that information that is bombarding it, all the time, and it applies to whole groups of people. So I think it's important that we recognize it, that it exists, and that we try to kind of limit, maybe its impact. And I think in medicine we were trained to use race and ethnicity as a one-liner, and it may be a problem sometimes, leading to some of these implicit bias that we have. For example, if a doctor is very busy and has very little time, and he sees a patient as a Black woman with congestive heart failure, those implicit bias are likely to be operative. And that compared to, and that may make the patient really kind of feel like the doctor does not really care, or they're not going to build that trust that is so important. And therefore the medication may not work, consequently. And if to the opposite, if we have a doctor that really kind of takes the time to really discuss with the patient, and instead the same doctor sees a Mrs. Smith as a retired teacher, mother of 4 children, who lives in Selma, Alabama, I think getting to know that patient allows for maybe better individual care and maybe shared decision-making approach, which is so important in what we do every day. What do you think is the best way, Antoine, what's the best way to use race and ethnicity in clinical practice?
Yeah, so I actually sit on the Diversity and Inclusion Committee for the American College of Cardiology. And one of the things that Dr. Capers and Quinn Capers and Stephanie Mitchell have really made a big point of in the meetings that we have had for the D&I committee is that we have an implicit bias problem, not just in healthcare, but in our healthcare system in general. And the most important part about understanding implicit bias is to be open to determining whether you have implicit bias or what implicit biases you have and how they could potentially impact your patients. You have to be open to the idea of the fact that you could possibly have some bias that you really don't realize. And one of the things I think that is really important now, especially as we talk about the population aging and more people having access issues. There was a recent article that analyzed the US Census, and it showed that the percentage of the African American population age 60 or above was about 8 to 9% now. And in the next 30 years, it will be double that, almost 20%. So that means 1 out of every 5 African-American people will be over the age of 60 and will likely have a higher risk for presentation to the hospital for some cardiovascular disease, most significantly heart failure. And so if we don't understand how to navigate these cultural determinants of healthcare now, then we will be at a loss when the population becomes most decidedly minority in this country, which will likely be by 2050. Having an understanding of the culturally significant barriers to access for patients is going to be eminently important. For instance, we have a Disparities project focused on structural heart disease, and we noticed that African-American patients are less likely to get transcatheter aortic valve replacement when they have aortic stenosis. They're twice as likely to get surgical aortic valve replacement, which is attended with a mortality risk that's about twice as high. But yet and still, we have a very significant proportion of our population who's African-American who does not have access to transcatheter aortic valve replacement for one reason or another. We thought it was because they might not have insurance. They might be hourly workers or low-wage workers that their employers don't pay for their insurance. But then we did the research, and 92% of people in Louisiana have some sort of insurance. Now that we have Medicaid, Medicare, or private insurance access, and a large part of it is due to the Affordable Care Act. So it can't be because they don't have insurance and don't have access as a result of that. So we had to look at other things, and there are things like proximity to specialists and specialized care. And Dr. Clarkson is certainly an expert in the care of patients in rural areas in Alabama and all over the South. They may not have transportation to go spend a day to go to the doctor's office where someone knows how to take care of them. They might not have childcare because their kids are being homeschooled because of the pandemic. They might not have the opportunity to be able to take a whole day off work and not have those wages so that they can support their family. So all of these culturally significant determinants of healthcare are going to become eminently important. The chronic disease, obesity, and lack of safe places to exercise, these things are generations old in the making. It's important to have an understanding of the potential of these kinds of social determinants to impact a patient's ability to get to the doctor or to have access to this technology. And these kinds of biases are sometimes just unfathomable to people who have never had to endure them. My daughter is a first-year medical student at LSU, and I had a group of her friends on the other day, and we were kind of having a discussion about COVID on a Zoom call. And my question to them was if their classmates that were not minorities really understood the impact of hesitancy in the Black community for medical studies and for medical establishment, and how they feel insecure about experiments like the Tuskegee experiment and how that actually causes some hesitancy with vaccines. And a follow-up question I had was, how would they discuss these issues with their non-minority classmates in order to be able to help them understand these factors that contribute to access to care that people may not have ever even considered. And so implicit bias is not necessarily something that is something that you are going to be actively having a bias because of these reasons, and it may just be a lack of knowledge or empathy because you haven't had those experiences. So having a conversation about it is one of the most important things, and having focus groups and work groups in the workplace, in the establishment, will help reduce these kinds of institutional implicit biases that minority patients experience.
Stephen, you were just out of fellowship. How is race and ethnicity used in clinical practice in the teaching hospital?
Yeah, so, I think that there's a couple of kind of important issues that were brought up here. I think, I think of two things here. One comes from your introduction, and I think what I find powerful and still happening a lot even in the training wards is the use of terms of non-compliant or a frequent flyer, as you said, and those terms. I think those are used kind of in a colloquial sense, but those feelings are pervasive. And until you have a set method of understanding social determinants as far as it pertains to patients, I think you end up labeling patients in these manners when in fact there may be another underlying mechanism. I think anecdotally, for instance, there's the issue in diabetes care and chronic disease management where patients are non-compliant, but perhaps they're homeless and don't have a refrigerator, so they can't refrigerate their insulin. You have, I know in the HRSA clinic, they preferentially prescribe medications that are less costly for patients, but instead perhaps they're missing out on newer therapies like Entresto or SGLT2 SGLT2 inhibitors. So I think first off, we have to recognize when we're labeling patients in this manner, what does that mean? What does that mean underlying? And what I try to do for at least my trainees is you have to recognize what's happening and what's going on in the patient's life. If you're having one of the great breakthroughs in therapy, particularly for Black patients, was ISD and hydralazine for heart failure. That's a 3 times a day medication. So if you label someone non-compliant, figure out why. I mean, I can't even really take a medicine daily without forgetting every once in a while. So taking 2 medicines 3 times a day is an awful lot. So I think that's one thing. And then I think number 2, classically, we would always present patients using race and age as these qualifiers, as we thought that these were significant biologically, right? We said, certain medical conditions may run in older folks or in certain racial groups. But in fact, as the census is probably going to tell us, as we've gotten more racially diverse in the U.S., I'm not quite sure that really holds up. There's a great anecdotal story from an NPR podcast where they presented a younger patient that she had, I think, it was upwards of 9 different ER visits for shortness of breath, cough. And she was a 9-year-old Black girl and ultimately had cystic fibrosis. But this was never diagnosed because she was presented as a 9-year-old Black female, when in fact, she was probably multiracial and had cystic fibrosis. So I think having these, these are all sources of this implicit bias that we're talking about, and recognizing that, as Dr. Keller said, is important to understand what is the reasoning behind why we're doing some of these things, and look at it from the patient perspective to understand what's happening in real time and kind of what we're using these qualifiers for and what they really mean. And I think those are kind of important ways to try to at least recognize that there is implicit bias that's present, not only personally, but in a system-wide issue as well. So
I think,
Alan, I think that it's really one of the things that I think is most important, and Dr. Clarkson has done some fantastic work on rural health and the impact of poverty on access to healthcare. And you mentioned the United Way. They've done a study called the ALICE study, which tries to assess the level or degree of poverty by county in America. And their studies are very powerful because of the fact that they really illustrate the pervasiveness of poverty, especially in the southern United States. At least that's where it's most remarkable and most relatable for us, I think, since we're here. But the impact of poverty is something that you don't necessarily stratify people by race and poverty, but I think that poverty has as much an impact, if not more of an impact, on access to care as race does. And I had a conversation recently with some of my colleagues at Medtronic, and they were trying to craft a message to help people understand that they want to be as inclusive of all different racial and ethnic groups in their message. And they brought up the point that poverty is a really significant risk factor for not being appropriately treated in cardiovascular medicine as well. So we should, I like to think about it as access in disadvantaged communities, not necessarily stratify them by race, because there are a lot of people who are disadvantaged that are not in minority groups, and it's important not to forget them too.
That's a very good and very important point. The geographic disparity, being in a rural environment, whether you're white or Black, it will be difficult to have access, to care and get the appropriate treatment needed sometimes. And I guess you're right. Race and ethnicity, a lot of times, is meant to describe social factors. Maybe they should be described separately. I think it would be important to have race and ethnicity particularly when we talk about genetic ancestry, where it could be related to occurrence of disease, like the example of Steve little black girl with cystic fibrosis, which is, hardly mostly seen in white people, but she had some, ancestors and grandparents that were white, and therefore, is carrying the gene. So I think that's really kind of very, very, very good points altogether. So as a healthcare system, we may be also lacking a comprehensive and community-based and mostly patient-centered approach to help implement and carry out some of the medical instruction and therapies that we have. So let's go ahead and let's start with discussing congestive heart failure and treatment with Steve. And Steve, if you could maybe start and talk about maybe what is geographic diversity in healthcare, particularly when it relates to heart failure. And if you could describe for us some of the call to action by the American Heart Association.
Right. So I think kind of what this brings up, and I'll kind of start from really the beginning as it pertains to cardiovascular disease and heart failure. But really, this mirrors really from all-cause mortality, cardiovascular mortality, and heart failure mortality. So these trends kind of mirror each other. But when talking about the geographic disparity, I'll kind of start from the beginning. And if you look epidemiologically at trends in cardiovascular disease and heart failure specifically, over the last, 40 or 50 years, we've seen pretty dramatic decreases in all-cause mortality and heart failure-related mortality, mostly due to innovations in medical care and device therapy and stuff like that. And so what you see when you examine those curves a bit more closely is that in the last maybe decade to 2 decades, we start to see this great kind of mortality benefits start to decline, and we start to see a mortality curve leveling off. And this is in spite of, new medications like Entresto or SGLT2 inhibitors or CRT device therapy. And so it begs the question of what's happening, what's going on that our mortality rates are not declining like they were despite having continued innovation in the therapeutic realm. And so if you look at that, you say, well, perhaps it's related to health disparities. And as you mentioned at the beginning of this conversation, what that is defined as, and one of those areas that the NIH really focuses on and the CDC and everywhere else is geographic location. And so if you look, the AHA's call to action, this is a paper that was Dr. Harrington did, and was, I think, published last year, kind of actually at the beginning of the pandemic or so. But in there, they have a nice mortality curve that shows from around 1990 on, you see this split in urban and rural all-cause mortality. And you start to see there's a gap widening where rural dwelling individuals are having worse mortality than those living in urban communities. And so and like I said, that same mortality curve really is mirrored in cardiovascular disease and in heart failure. So it kind of begs the question of what is that and where is it happening and kind of what's going on. So when I looked at this kind of a bit more in depth, what you find is that if you look at what kind of rural means, so globally from the US, about 20% of individuals live in what's classified as rural counties or kind of rural areas. However, about 65% of those live east of the Mississippi, and around half of them live in the South Census region. So the majority of these rural dwelling individuals are living in the Southeast, kind of right smack where we are in Louisiana, Alabama, Georgia, and South Carolina. And so if you look at those same mortality curves in those areas, what you see in particular for heart failure is this really kind of dramatic, as we said earlier, health disparity, right? Difference in all-cause mortality and heart failure-related mortality in the Southeast, and in particular in Alabama. And I think it's kind of a milieu of several different things. I think there's health-related disparities, higher obesity rates, more tobacco smoking, less optimal cardiovascular health. There's also social determinant disparities. There's lower income in rural communities. There's lower education. But really, when you look at kind of as far as health is concerned, it's really this access to care. And so, I have a paper that I'm currently working on where we looked at a clinic here at UAB that's particularly serves underserved individuals, so people that are uninsured or underinsured. And we looked at what was their rate of actually making it to their first clinic appointment after a heart failure hospitalization, and what predicted that. And if you looked at the data, what it shows is that although not statistically significant, rural dwelling individuals, all comers, had lower rates of being able to show up to their first clinic appointment. But what you found is there was a difference along racial lines where white Americans that lived in rural communities had a much higher rate of presenting to their first clinic appointments than did Black Americans that lived in rural communities. And if you looked at that even further and looked at distance from clinic to their home zip code or home address, you saw that that relationship was even stronger. So what you see is that there's a difficulty in getting to clinic for these individuals. And in heart failure specifically, the clinic intervention, as we've seen in data from, the early 2000s, multidisciplinary heart failure care delivered at a clinic, usually with specialist care, dramatically improves heart failure outcomes, right? And this is where you can get access to CRT or medications. So if we can't get the patients to the clinic, then it's hard for them to have that improved mortality that we've seen with all of our medications and device therapies. So that's a little bit of, I guess, a kind of rundown on a little bit of the geographic disparities, and really, in my mind, what seems to be central to that is really getting these folks the ability to access their care. When we know that we have therapies that work to improve mortality, we have to get it to the folks that need it.
So with that said, I mean, I think it was just published last month in the JACC Heart Failure, and it was the difference of care in patients with heart failure between patients that were enrolled from Canada and versus the U.S. And finding out that actually there was more frequent hospitalization in our patients from the U.S. and less of them were treated with the guideline, guided therapy compared to Canada. Obviously, there was not that much diversity in Canada. I think there was one Black patient. We had obviously more African American enrolled in the U.S. But, this was part of a trial that, involving clinical research, where actually, most of the time you enroll a patient in the research, you even pay for their transportation.
Right.
The office visit is free. Even with this kind of like almost universal healthcare kind of system where everything is provider facilitated, I should say, it's still, we could not implement, the same measures as in Canada, which saw their doctor more often than we did and so forth. I mean, how do you explain that? I mean, how can we solve this?
That's actually, there's been another paper that was a little bit earlier than that. And I think it was out of Canada as well, but it also showed that transportation still was an important predictor of people getting to clinic, even within a universal health system. So, I think that transportation, as you said, is a tough thing, but even when that's paid for, it goes back to what Dr. Keller mentioned earlier. And then there's the idea behind social determinants of health, right? So even if I pay for your transportation, who's going to watch your children? But even if I pay for your transportation, are you going to be able to call out of work for that day to come to see me in the clinic? So I think that's where the social determinants become important. And, I think that when you look at, I hate to keep harping on transportation, but it's such an important aspect when it comes to care here. If you think about, anecdotally, I had VA patients that I've been seeing over the past several years. And the VA system is probably a closer system to universal care that we have in the U.S. Than most. Even then, during the pandemic, I had several of my patients, heart failure patients, again, this is anecdotal, that were scheduled for in-person visits. But with the availability of so-called telehealth visits, they chose for me to call them on the phone rather than to them drive to Birmingham. And when I called them and asked, hey, we're allowing people to come back in person, what's going on? They said, I just didn't feel like driving an hour and a half and waiting in Birmingham traffic to see you when I could call you and talk to you on the phone. And so I think that it gets to the idea that, we can evaluate these things from a research perspective, but there's this whole other aspect to care that I think we're finally recognizing really bears importance in how patients get through life, and that's the social determinants. And I think that's really where understanding those and how those impact can really guide maybe policy and how you change the environment that these folks live in, and can improve their access to just really getting in that front door of the clinic or of care.
Now, Steve, you did a very interesting and important study, and it was about integrating telemedicine and how it could affect clinical outcomes and rehospitalization in patients with heart failure. Do you want to talk about that a little bit?
Well, yeah, sure. So, that particular project is a little bit ongoing, but essentially it piggybacks on the data that I discussed just a few minutes ago, and trying to understand the predictors of getting folks into clinic, and understanding that there was identifying a significant disparity in that getting folks into clinic for the first time. And then it led us to trying to develop a way to deliver the same type of care you do, multidisciplinary care in a heart failure clinic space, how you deliver that via telemedicine. And so, like I said, these data are ongoing, actually at the current moment. But the study approach was actually twofold. One, it was identifying that. Two, it was also using this. We've had a year that unfortunately has been under a pandemic, but has fortunately forced us into the world of telemedicine and how to deliver care across distance, right? And we've used some of the technology we've had over the past several years that we've developed to try to do that during this period of time. And this is a great opportunity to figure out what it is that works for patients and what doesn't. And I think some of the things that have come out of that, again, this is not analyzed data, but some of the stuff that's come out of that is patients have an easier time engaging in telemedicine if they know the care team, if they've encountered the care team before, versus a kind of a brand new visit. A big barrier within Alabama is internet access and telecommunication access. I think that's a big portion. There was data from our health system that showed there was a significant disparity over the course of the pandemic in who used video-based visits versus telephone-only visits, and that was and there was an age disparity and a racial disparity. Folks that were older were less likely to use video-based visits. Minorities were less likely to use video-based visits, and those that were underinsured or uninsured were less likely to use video visits. And then when you talk about that in terms of heart failure, the Heart Failure Society of America said that virtual visits would be is a better use of a telemedicine visit for heart failure patients specifically, and so perhaps there's a care disparity that's happening there. So again, these are projects that are ongoing, but it's in the effort to understand what parts of telemedicine, whether it's telemonitoring, video visits, and those things can be delivered across distance to patients with heart failure to get the same benefit from a multidisciplinary clinic approach that you would get in person.
You actually network with either through nurse practitioners or do you network with remote access to evaluate these patients, remote clinics within Alabama?
So we have not done that yet. What has been going on is that it's a central clinic location, and then you use telemedicine approaches with the patient in the home. Now, what you're talking about is actually in the AHA's call to action is a great model for how to increase care quickly into rural communities, and that's with this hub and spoke model. I think that's going to be a great way to facilitate building infrastructure in rural communities without needing a dramatic investment. I think it's hard to develop infrastructure in rural communities just because they operate on a lower overhead anyway. And so if you already have the infrastructure built at a place like UAB, you can transfer that to rural communities and outlier clinics easier than trying to build up an entire health system in a community that already operates on a low overhead. And so I think those are things to do going forward. Currently it's really just delivering care in the home right now through telemedicine. But I think building rural clinics and hub and spoke networks would be the better way to do it so that you can have better infrastructure without needing a complete rebuild of rural communities.
To be able to reach out to the patient and really patient center, I think would help maybe solve some of the access problem.
Yeah.
Let's talk about the aortic valve and aortic stenosis, which is obviously one of the passion for Dr. Keller. We know that aortic valve stenosis obviously is the most common valvular heart disease that we have. It's the third common cause after cardiovascular, after hypertension and coronary disease. The risk factor for aortic stenosis are, very, very common, particularly among minorities. We're talking about hypertension, smoking, chronic renal failure, diabetes, congestive heart failure, and age, and maybe a little bit less so in regards to the bicuspid valve. It's a very prevalent disease. I mean, we're talking about 12% of patients in patients that are older than 70 years old. That's about 3 to 5 million people. And in terms of severe aortic stenosis, we're talking about over 3% of the elderly population. That's probably about, close to 1 million individual. So we know that the surgical aortic valve replacement and the TAVR are highly effective treatment of it for aortic stenosis, but these innovations have not been disseminated across the whole spectrum of patients with AS. Studies have shown that treatment disparity affecting the underserved minorities, and we don't know what it's related to. Is it the disease prevalent? Is it the genetics? Is it social demographics? Or is it a referral, a treatment bias? It seems like aortic stenosis is underdiagnosed and therefore may be undertreated. So first question, Dr. Keller, who are really the underserved, particularly when we talk about the TAVR registry, which, we have about almost 94% of the patients that are white and only something like 3.8% that are Black. On the other side, when we look at, there's a recent study that showed that Floridians, living in the rural area that had an additional 44 miles to drive to get the TAVR, they ended up having a 7-fold lower rate of TAVR utilization. And we're talking about over 6,000 patients. 91% were white, but they were living in rural areas. So who are the underserved, for patients with aortic valve stenosis, really?
Yeah, I think it's a really good question. And I would like to tell you the answer, but I don't think we know the answer for a couple of reasons. One, the prevalence data that you referenced in your intro really does use incidence data and census data and try to retrospectively predict what the prevalence is. We've never really done a large-scale prevalence study in the United States in the general population. And I think the biggest critique of using those statistics is the fact that there's some selection bias because these people are already known by their doctors. And so one of the things that we have set out to do with the screening project that we have, the Structural Heart Disparities Project, is to try to get an idea about what a good sense of what the prevalence of valvular heart disease is in our community. And so we've gone out into the community to rural areas and to faith-based organizations and community centers and pharmacies and places where we're likely to find older folks, assisted living communities. And we've just listened to all of these people with a digital stethoscope and done point of care ultrasound with a butterfly probe on all of these people. And we have not published our data yet, but our initial review indicates that the prevalence of valvular heart disease in general in our community is about twice as high as what we would expect it to be. And there are certain subpopulations of patients that have an inordinately high prevalence of valvular heart disease that is not known by their doctors or not appropriately diagnosed and treated by their doctors. We have found, for instance, about 10 to 15% of all the people that we screen that are over 60 have either atrial fibrillation or some valvular heart disease, aortic stenosis or mitral regurgitation that no doctor had ever told them about. And they didn't have a doctor and were not under a doctor's care for those things. And, it's quite evident that a lot of these people are presenting to the emergency room in heart failure after having had these conditions for some time, and it is unbeknownst to them or their physicians or anybody else. So one of the things I think that is really important for us to wrap our arms around with regard to understanding what communities or what ethnic or racial groups are disadvantaged with regard to valvular heart disease is trying to understand how all of these social determinants that we spoke about earlier impact whether patients actually present to the doctor at all for these kinds of conditions that don't happen overnight, but certainly do impact their livelihood and their longevity. We do know that we have disparities in diagnosis and treatment of valvular heart disease in Black and Hispanic communities, as well as you mentioned, in communities that are rural. And certainly there's some data to indicate that patients who have a higher degree of poverty in their community will necessarily have surgical as opposed to transcatheter therapy. I think one study that I recall said that for every 10%, $10,000 increase in median household income, the patients have a 10% greater chance of getting transcatheter therapy as opposed to surgical therapy. So again, I want to emphasize the fact that poverty and rural location have as much or more to do with the fact that certain racial or ethnic groups don't get access to care equal to that of patients in the majority population. So finding out that number, we don't know what we don't know. We don't know how many people have valvular heart disease in America in any definitive way yet. And so knowing that will be able to allow us to devote more resources and time and energy to certain populations where we see that the prevalence is higher. You alluded to the fact that we have all of these fantastic clinical studies, major multi-center studies for transcatheter aortic valve replacement, and only 3% of the patients in those studies are Black or Hispanic, when they constitute 15%, and sometimes in California, as much as 40% of the population. This is a problem too. And, when you, Dr. Clarkson and I were having a conversation offline about academia and access to patient populations that would be equivalent to the population in any particular geographical area. And there are barriers to enrolling patients who would allow you to be able to have a clinical study in which the proportion of patients was congruent to that in the general community in which the study's being done. But these barriers have a lot to do with access and familiarity and things that really we can't control because they're structural or institutional, built into the system. And until we make those kinds of efforts to be able to reduce those barriers, then we're not going to make very much headway in having some sort of parity or equity in the treatment of things like structural heart disease. The only way that the federal government or state government is going to be able to devote resources to these things is if we can get accurate, reliable data on how many people in the communities that we're talking about actually have these diagnoses. So that's probably the biggest impediment to achieving health equity, specifically with regard to valvular heart disease, but certainly with regard to a lot of other things. One of the really illustrative pieces that I have read recently that really illustrate the magnitude of this problem is that NPR did a study recently on COVID testing and vaccine sites in Baton Rouge, where I live. And they noticed that 10 of the 14 diagnosis COVID testing sites in Baton Rouge were located on the south side of town, and only 4 on the north side of town. But the population, a vast majority of the population lives on the north side of town. It just happens to be where the population is mostly African American. And so this is true with COVID, and it's an institutional impediment to these people having access to care. But it's not just true of COVID. It's true of those patients with hypertension and heart failure and structural heart disease as well. It's not just COVID specific. So there are some institutional barriers and determinants of healthcare that we have to get a hold of. And the only way that we're going to be able to do that is to provide information that will allow our elected officials to be able to craft legislation to increase resources in those areas.
Yeah. Well, point is well taken. As a matter of fact, we have no idea what is the prevalence of aortic stenosis in the minority. I mean, all the data that we have, this Optum cord, for example, is claim-based from hospitals and clinics, but you have to go to a hospital or clinic to be able to be part of that census. I mean, we're talking about in 2016, you had like 6,500, white patient with critical AS and underwent, surgical or TAVR versus 260 Black patients. Obviously, it's not really kind of matching the reality that we have in our population. And to your point about your study of the EKG and the echo stethoscope, there was a study of 2,800 elderly patients who all underwent echocardiogram at a long-term facility. And actually, they found no difference in prevalence of aortic stenosis in white versus Black versus Hispanic. So, this is, I think, the work that you're doing, going out to the community and really, performing a screening, for aortic valve disease or in this, just with a stethoscope. I mean, it would be, very, very informative. So what are the patient barriers, Antoine, that you perceive or that you've seen maybe in your practice?
Yeah, so a lot of them have to do with the things that we discussed in the last part of our segment. Dr. Clarkson was pretty good at laying out the kinds of things, the impact that not having transportation has. There are some barriers, cultural barriers, like the patients do not want to go to the hospital and spend the night, however many miles away from the hospital that they are, because their family members won't be with them and they're afraid to be alone. So they don't have money for a hotel room. Sometimes they have to get a ride or someone in their neighborhood that can take them all the way, however far it is to get to the hospital or the doctor's office, and their ride has to wait around all day with them while they're in the clinic. There are so many culturally significant barriers that we have ignored. And the ACC has this Credo initiative, which I think is going to go a long way with helping people to understand what kinds of barriers exist and educating clinicians as to the importance of these kinds of issues in taking care of their patients with hypertension, for instance, or heart failure, or atrial fibrillation, or some sort of structural heart disease. These initiatives are helpful, and I wish that more people would take advantage of them.
Do you think, from the medical standpoint, do you think the patient presents differently? I mean, you have like a group of minority that have obviously all these comorbidities, including chronic renal failure and hypertension and obesity and diabetes. I mean, do you think they have the same symptoms? I mean, or do we know? I mean,
yeah, I think it's a really good question. What we do know from the TVT registry is that if a Black patient and a white patient present with aortic stenosis and get transcatheter aortic valve replacement, then their expectation of a favorable outcome is exactly the same. There's no difference. but yet and still the mortality rate for aortic valve replacement in general in the African American population is twice as high as it is in the white population, primarily related to the fact that more African Americans will get surgical aortic valve replacement as opposed to transcatheter valve replacement for one reason or another. So as far as symptomatology, I don't think that there is any significant difference. In terms of comorbidities, there may be in the incidence of chronic disease and relative malnutrition and so forth, that may be some racial differences. But I think that if you really analyze that information, that poverty or low socioeconomic status would probably have make more of a difference than what race the patient is.
Do you think there's some barriers also within our healthcare system? I mean, is there some reluctance to refer patients maybe, or to kind of, lose contact with your patient, or just problem delegating, or I mean, a lot of these patients are not referred even to a cardiologist.
Yes, and it's, there have been a number of studies that have been supported by the Association of Black Cardiologists that have tried to assess whether there was some selection bias in taking care of patients, matched patients who are Black or Hispanic as opposed to white. And there is no doubt that these biases exist. But as I mentioned early on in the podcast, it's really important to be open to the possibility that they exist. And many clinicians are close to the possibility that they would treat any patient differently for any reason. So really being open to the discussion, I think, is a major barrier that we have to overcome in general as clinicians in this country.
So Antoine, I mean, how do you think we close the gap? I mean, you talked about Credo a little bit. I mean, what is that exactly?
So it's an initiative by the American College of Cardiology designed to reduce racial and ethnic disparities by educating patients and physicians and families about healthcare disparities and trying to work together to develop just site-by-site solutions to the problems that exist, because it's undoubtedly there are regional differences in how people get treated and how they get referred. And it really is dependent upon people on the ground in the actual community to be able to try to reduce these kinds of barriers. Having a discussion about it and not being put off by the notion of healthcare disparities or health equity, I think, is a major step in the right direction. The only way we're going to be able to get there is to have more conversations about it. Race and religion and politics are things that decidedly inspire a lot of passion and disagreement. But I think that anytime we can have civil conversation about these kinds of things, it can't help but to bring whatever side you're on a little bit closer to the other side and try to come up with solutions to these problems.
But it seems like we need to extend the heart team approach, maybe to include the physician in the rural community, as well as treating primary care physician, and really kind of doing a lot of teaching and education, regarding.
Yeah, I'm a big advocate of programs like Vital Engine, which Dr. Johnson has been very instrumental in developing, because of the fact that it brings people together face to face and gives them the direct access to each other that I think we have gotten away from in medical care with the advent of technology that can help us reach more people without actually being face to face. I think that if we can bring people back together, talking to each other face to face or phone to phone, I think it goes a long way to helping improve that continuity and this collegiality that we have in medicine, or that we're proud of in our medical history, to be able to help people overcome those kinds of barriers.
Yeah. Steve, anything to add?
Yeah, I think those are all great points. I think it speaks again to the, going from the beginning, Dr. Keller kind of highlighted to us the difference in understanding incidence, prevalence, and aortic stenosis, and how there's this idea that perhaps there's a lower incidence, but in fact, when you prospectively enroll patients and actually give them the care, then perhaps you see that maybe the incidence or prevalence is not quite as different as we thought. And it speaks in the rural community, at least, to the fact that building that infrastructure and getting the care out there is what's important. It's hard to get TAVR in a rural community because there isn't a lot of folks that can do it. And when you don't have high dollar procedures, their overhead for rural hospitals is lower. And so what you see in the last decade or two is that you have a lot of rural hospitals that are closing because they can't cover costs. And so you're leaving more care behind. And you look at from the beginning, there's really only 9% of U.S. physicians practice in rural community, and that's to take care of 20 to 22% of the population. That's a pretty big disparity. And then if you look at rural counties, almost 75% of them are classified as primary care physician shortage areas. So there's not even primary care in rural communities. And then if you look even further within cardiology, there's about 50% of the cardiology workforce is really spread over and only about 20% of the elderly population. So again, there's a pretty big disparity as far as when you get to cardiology and specialist care. So really, it starts from the very beginning, and it kind of transcends all aspects of getting care, particularly for TAVR and things like that. And so, and even post-discharge, right? Transportation and distance are directly correlated to participation in post-acute care. So all these things speak to the fact that there needs to be infrastructure investment in communities that have what seem to be equal incidence or prevalence, or somewhat equal incidence or prevalence, and most notably have similar outcomes once the care is provided. I think that's also the central theme to this is once you get the care to the individual, they do just the same as everybody else. And so it's a matter of overcoming that barrier.
Well, gentlemen, it seems like we're just beginning the conversation. It's like so much to be done. Wanted to thank you for taking the time, Dr. Antoine Keller in Baton Rouge, Louisiana, great cardiac thoracic surgeon, and Stephen Clarkson at the UAB, starting, his cardiology attending rotation just in September. So really appreciate your time. Such an incredible knowledge about the subject, but again, so little that we know, and so much, to be discovered. Thank you, gentlemen. Thank you so much.
Thank you, Dr. Bouchard.
Thank you.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.